Hi everyone, today I'll be talking about AC joint injury. AC joint injury is a traumatic injury to the acromioclavicular joint with disruption of the acromioclavicular ligament and coracoclavicular ligament. It's more common in male and athletes. The risk factor usually high impact sports such as rugby and also MVA, commonly in motorbike accident. The mechanism of injury usually direct blow to the shoulder and falling onto the shoulder. For the anatomy, AC joint is a diatrodial joint with articulation between medial acromion and also lateral clavicle. There is a fibrocartilaginous interarticular disc in between the osseous element. The motion for AC joint primarily gliding, but it has a minimal rotational motion. The static stabilizer for AC joint, joint capsule, AC ligament, and also CC ligament. AC ligament has 4 components: superior, inferior, anterior, posterior, and it has controls the vertical stability. The CC ligament has 2 components, conite and trapezoid. Conite is the lateral medial structure. It attached to the clavicle about 4.5 cm medial to the lateral edge, and also it controls the horizontal stability. The trapezoid is the lateral structure. It attached to the clavicle about 3 cm. So the dynamic stabilizer for the AC joint is anterior deltoid and trapezius. Usually patients with AC joint injury presented with trauma or fall with complaint of pain over the AC joint, which can also radiate to the trapezius. Usually patient will have high impact injury, for example MVA, and then patient might have a limited range of movement due to pain. On examination, on inspection, there might be swelling over the AC joint. There might be abnormal contour of the shoulder compared to the contralateral side. On palpation, there might be tenderness over the lateral clavicle or at the AC joint. The ROM might be limited due to pain, and also there are 2 special tests that we can do to test for AC joint injury, which are the scuff test and O'Brien test. The scuff test is performed by doing passive cross-body adduction of the shoulder. The test is positive when there is a pain over the localized at the AC joint. In O'Brien test, it is suggestive of AC joint pathology when there's a superficial pain at the AC joint. For the imaging, we can do X-ray with AP view, Zanka view, and axillary view. AP view should be done bilaterally to compare the CC distance to the contralateral side, and the axillary view is done to look for the relation of the clavicle to the acromion. It is important it is required to diagnose type 4 injury where there is a posterior dislocation of the clavicle. Zanka view, it is performed by rotating the beam 10 to 15 degree equivalent and using 50% of the penetrance of the normal AP penetrance. It is used to calculate CC distance and also to measure the percentage displacement of the acromion related to the clavicle. The classification, usually for AC joint injury, we use Rockwood classification. There's 6 types. The type 1, the Rockwood classification looking into the CC and AC ligament integrity, physical examination, and also radiograph findings. For type 1, there's a sprain of the AC ligament, but there's a normal CC ligament. The radiograph usually normal. On examination, there might be tenderness over the AC joint, but there's no horizontal instability. In type 2, the AC ligament is torn and CC ligament is sprained. The radiograph also, on radiograph finding, the AC joint is disrupted with the CC distance less than 25% compared to the contralateral side. On examination, in type 2, there's a AC joint tenderness with horizontal instability. In type 3, both AC and CC ligaments are torn, and on imaging, there's increased CC distance, but 25 to 100% of the contralateral. The type 3 can be further divided into type 3A and 3B. In type 3A, there's a vertical AC joint instability with no horizontal instability. In type 3B, there's a vertical and horizontal instability of the AC joint. In type 4, both AC and CC ligaments are torn with skin tenting and posterior fullness of the clavicle. On imaging, there's a posterior lateral clavicle displaced. On imaging, the lateral clavicle is displaced posteriorly through the trapezius on the axillary X-ray. In type 5, the AC and CC ligament are torn with drooping of the shoulder. That does not improve with shrugging. On imaging, there is increased CC distance more than 100% compared to the contralateral. In type 6, it is rare. Both AC and CC ligament are torn with paresthesia. On imaging, there's an inferior dislocation of the lateral clavicle, lying either in the subcoracoid or subacromial position. The differential diagnosis for AC joint injury includes coracoid fracture, distal clavicle fracture, and AC joint arthritis. For the management of the AC joint injury, it can be divided into operative and non-operative. For non-operative, usually it is reserved for type 1, type 2, and type 3. For acute injury, we can use Price principles. We can prescribe patient with NSAIDs to reduce pain and swelling. For example, Celebrex. We should advise patient with for ice compression, about 30 minutes for every 2 hours, and then we can immobilize the joint with arm sling for maximum up to 2 weeks. We should also start early RM exercise for the shoulder, wrist, and also elbow. Shoulder strengthening exercises also should be started early. We can start with isometric exercises and then progress to eccentric exercises with weight, and then not to forget the scapular traction exercises. Other than that, we aim to gain the functional motion by 6 weeks and to return the full normal activity by 12 weeks. For chronic AC joint injury, the main things is to do the shoulder strengthening exercises and also activity modification. We should advise patient to reduce overhead movement and avoid lifting heavy things. The complication for non-operative AC joint injury treatment is AC joint arthritis and chronic subluxation and instability. For surgical intervention for AC joint injury, usually reserved for type 4, 5, and 6. It is indicated for usually the surgical intervention is the main aim is to restore the CC interval. It can be done either by open reduction, internal fixation, or ligament reconstruction. The surgical intervention also indicated for type 3 injuries, for laborers, elite athletes, or patients who have cosmetic concern. The chronic type 3 AC joint injury also that have failed non-operative treatment also is indicated for surgical intervention. The contraindication for surgical intervention, skin problems over the operation site, and then there's a patient who have patient who are unable to comply to the post-op rehabilitation. The rehabilitation program for the post-operative management for the ACJ injury usually aim to immobilize the joint for up to 6 weeks without the range of motion exercises, and then the aim is to gain back the function by 12 weeks. Thank you.